problem of awareness during anesthesia, particularly the NAP5 project. Really, this talk is around implementing the NAP5 results into practice and guiding the research agenda. By way of outline, I'm going to remind everyone of what NAP5 was. This is the 5th national audit project of the Royal College of Anaesthetists in the United Kingdom, and present its main results. And I'm also going to show how it's been disseminated since, and touch upon some of the national and international awards that it obtained, and how it's informed clinical guidelines, training, and research. And I'll offer some conclusions. NAP5 was the largest ever study into accidental awareness during general anesthesia, and you'll see this acronym AAGA for that accidental awareness, which I'll use a lot in this lecture. It was a project that covered all United Kingdom hospitals in the national health system. That was 3 million patients anaesthetized in the year, as we knew as part of the project. It was a service evaluation that created an anonymous registry over 1 year of the patient reports of having been accidentally aware. It was an international study because it included the Republic of Ireland, which is a different country, and it included the first really comprehensive activity survey of anesthesia in the UK. This provided denominator data to analyse our results. It involved a very large multidisciplinary team, not just of anaesthetists, but neuroscientists, psychologists, medico-legal experts, and patient representatives as well. This is a plot of the main studies, if one's interested in the topic of accident awareness. These are the big studies that people consult in the literature, with the first author or the study names on the x-axis. And you'll see there NAP5 right at the end. I've left blank because actually when you put the NAP5 scale of the number of patients that we studied or collected, it just dwarfs everything else into sort of oblivion, as it were. It was a huge study by comparison. So the number of, that was the number of denominator cases. The number of awareness cases, similarly, is dwarfed, other studies are dwarfed by NAP5 when plotted onto the scale. So we collected around 300 cases of different types of awareness as compared with the others. In fact, the NAP5 cases exceed the sum of all previous cases of awareness collected in the literature. I'm going to discuss now the main findings of this very large study. First, around the incidence of awareness. And what we discovered was that really the incidence depends on the context, and we, in fact, graded the type of awareness. So we realized that it wasn't a single entity necessarily. So, for example, when neuromuscular blockade was used, we found an incidence of 1 in 8,000 general anesthetics. In obstetrics, cesarean section, the incidence was very much higher at 1 in 670. In pediatrics, it was much rarer, 1 in 61,000. And when no neuromuscular blockade was used, it was almost undetectable at 1 in 136,000 as really the upper estimate of awareness. The overall aggregate incidence was 1 in 19,000. Now note that if you interview patients after anesthesia and ask them certain questions, which is called the Bryce interview, you actually get an incidence of 1 in 600, and this is repeatable in the literature. So there's this disparity between the spontaneous reports that we obtained in NAP5 versus the incidence obtained when you ask patients directly after anesthesia. And I'll come back to that theme later on in the lecture, particularly around this very high incidence in obstetrics, which, as you can see, the spontaneous reports are very close to the Bryce interview incidences. So this is the same data, really, just to show you how we presented the different contexts in which awareness was happening, and therefore the different incidences that could be obtained as a result of our analysis. Once you have the incidence, we looked also at the sort of risk factors that were predisposing to awareness. And this is what we found, that it was more common in young middle-aged adults versus pediatrics or the very elderly, more common in females, more common in the obese, in emergency surgery, particularly when rapid sequence induction, RSI, was being used. It was more common when junior staff were the main anaesthetist, and of course more common when paralysis, neuromuscular blockade, NMBs, were used. And because of all that, it was more common in certain specialties like obstetrics and cardiothoracics, where in obstetrics patients can be obese, and in these specialties neuromuscular blockade is the norm. Interestingly, things that were not risks in themselves and equally not protective were ASA grade. That didn't seem to be influential, and as I've mentioned, extremes of age. Interestingly, we didn't detect that nitrous oxide made any difference to the incidence of awareness, and similarly the use of midazolam at any point during the operation was also not a feature. You will see later the use of EEG or bispectral index monitoring was not influential on the incidence of awareness. What we did was we plotted these risk profiles using these graphs where the bars represent the incidences in the awareness study, and the lines represent the incidence in the activity survey, the sort of general incidence in the population. So, for example, when the bar exceeds the line, as it does here in obstetrics in the middle, that means that this is a risk factor for awareness. And if it's the other way around, then you could argue it's protective against awareness. And these are the bars that, the full plots that we presented, and I will zoom in on these to explain a little bit further. So, for example, certain drugs, such as thiopental, are risk factors, we discovered, where the bar greatly exceeds the height of the line. And of course, in the UK, we had an explanation for this because unusually, and this is not reflective in international practice, thiopentone is used exclusively for rapid sequence induction and particularly in obstetrics. In general inductions, it's only used in 3% of cases, but it's used in the United Kingdom in almost 90% of rapid sequence inductions and more than 90% of obstetric inductions. And so this is unusual UK practice for this drug. This is clearly predisposing to accidental awareness. And since NAP5, we know that this practice has changed. If we look at TIVA, we see that it is a risk factor. Total intravenous anesthesia, the bar exceeds the line. And the reasons for this are really around monitoring, that people were not using any form of monitoring and lines were becoming disconnected, and there was uncertainty around dosing that was leading to this. Equivalently, we do see that sevoflurane is arguably protective, and this raises the possibility of some agent-specific effects in terms of causality of awareness. If we take a closer look at TIVA, total intravenous anesthesia, we see that it's a risk, but it's particularly the non-TCI. This is the target-controlled infusions, the computerized infusions, that are safer. And also where there's a mix of volatile agent and then a propofol infusion, such as one might use in a transfer of a patient, say to a CT scan or elsewhere. These were the biggest risks. Target-controlled infusions were the safest. They sort of doubled, just under doubled your risk, whereas others more than doubled your risk of awareness. Now, this is, as you know, target-controlled infusions are the computer-controlled infusions, and this is of relevance to practice in the United States, because unless things have changed very recently, the United States is the only country in the world that doesn't allow target-controlled infusions for reasons which are entirely unclear. They are clearly safer, and as NAP5 has shown in terms of preventing awareness. So it'd be really interesting to see if what we found in the United Kingdom is mirrored through a cross-national study where a country that doesn't allow these TCI infusions may have a higher rate of awareness with non-TCI use than other countries that are using TCI, or the rest of the world that's using TCI. A novel message of NAP5 is that the commonest time that awareness occurs is during induction. Now, all those previous studies that I showed you studied awareness during the maintenance phase, but NAP5 discovered that actually it's during induction that is when awareness occurs. And the second commonest time is emergence. So it's really at the dynamic phases of anesthesia that we get awareness. Awareness during maintenance phase, which is the focus of most of the studies in the literature, is in fact uncommon. And when awareness occurs, it's perceived by the patient as being very brief, a maximum of 2 minutes and often of just a few seconds. Another novel message is that paralysis, the use of neuromuscular blockade, is the main association. Awareness does not occur, it is not a problem complained of by patients when no paralysis is used. I mean, that is the real novel message of NAP5. The maintenance phase during surgery forms the minority of the proportion of cases, as I've said. This discovery that total intravenous anesthesia is a genuine risk is a novel message as well. This is a graph just emphasizing how awareness is commonest during induction and emergence, with maintenance forming in totality just under a third of cases. The biggest risk factors, if you stand back and look collectively, is what I call this sort of unholy trinity that is almost guaranteed to lead to accidental awareness. This is where one uses neuromuscular blockade, but one doesn't use any monitoring, one doesn't use a nerve stimulator, and then finally one doesn't reverse the neuromuscular blockade. So that triad of practice is very risky for inducing awareness in a patient. And this is important because what we discovered was that distress was caused by the paralysis much more so than pain. So when we interrogated these patients, we asked them what it was they'd experienced and what it was that was causing their distress. And it was paralysis that was much more than pain, and obviously the two together were the most potent. Overall, NAP5, being such a big project, made 64 recommendations for practice. National guidelines, national recommendations on drug packaging and training. It directed recommendations to institutions where it recommended adoption of a psychological support pathway that I will touch upon, how to plan operating lists, how to use checklists, and how to consent patients for the risk of awareness, particularly when it was recognized they were high risk for this side effect. Recommendations also for our personal practice, in our behaviors, how we speak to patients about the problem of awareness, and about how we should take care with planning our anesthesia, how we manage the airway, and the drugs that we use. I'm now going to turn to the professional scientific progress that's arisen out of NAP5. I mentioned the psychological support pack, and this is a formalized way of managing a case of awareness that becomes reported. And we divided it up into 3 sections. That we first meet with a patient, which is a face-to-face meeting where we listen to the patient's story and that we are sympathetic and accept that they've had a genuine experience. Remember, in the old days, very much pre-NAP5 and certainly pre-modern scientific advances, there was disbelief that anyone under anesthesia could have been aware. We now know that this does happen. This is a genuine problem. The second is the analysis phase, where using the learning from NAP5, we try and understand what may have gone wrong. Was it an underdosing of anesthesia? Was it disconnection of a total intravenous anesthesia line, failure of a vaporizer, etc.? We try and understand and analyze what had gone on. And perhaps the most important is the support phase, which is early psychological support, where we actively engage psychologists to look for early signs of post-traumatic stress. NAP5 has informed guidelines in the United Kingdom, what we call the mandatory monitoring guidelines. So, for example, low agent alarms for end-tidal gas monitoring, the use of nerve stimulator whenever neuromuscular blockade is used, and the use of depth of anesthesia monitors with total intravenous anesthesia. And this last is informed by the reality that because there's no end-tidal level for intravenous anesthesia or no way of monitoring plasma levels, the depth of anesthesia monitor in this context is almost the only way of knowing that some agent is getting in and affecting the brain. And so this was embedded into the 2015 guidelines, and it was re-emphasized in the 2021 guidelines. There's been a set of guidelines in 2015 on managing the obese patient with recommendations of how to dose anesthetic appropriately so as to prevent accidental awareness. And again, because this is a high-risk group, consider early and frequent depth of anesthesia monitoring in this particular patient group. Airway management. We identified that difficult airway was a risk factor because while people were struggling to manage the airway and say prolonged intubation, that was the time that the patient was actually not getting anesthetic and therefore awakening and often being paralyzed. And this was the high risk combination. So we actually promote and recommend an advanced awake or sedated intubation because this is something that patients won't be accidentally aware about. They'll be consented and prepared for it. And notably, patients who are difficult to intubate are also difficult to extubate. And so it is crucial in that extubation plan first to reverse the paralysis and then to lighten the anesthesia, not the other way around. The patient must first be fully reversed before anesthesia is lightened. Otherwise, they end up in a scenario where they may awaken paralyzed or partially paralyzed. Training for intravenous anesthesia is really important, and the Society of Intravenous Anesthesia in the United Kingdom has taken this forward with a formalized training package. And of course, that includes training in the target controlled infusion that, of course, are absent in the United States. We've permeated training in Royal College of Anaesthetists exams, what you would call the board exam. So questions like, what are the main NAP5 recommendations, obviously is going to require all candidates to read and learn around the NAP5 report. So that is now embedded into basic training. Now, I mentioned obstetric anesthesia, and one of the package of recommendations that NAP5 made was around future research. And we did recommend and suggest, look, this high incidence in obstetric anesthesia is something that ought to be investigated further. And our group, my group, has taken this forward, and there are a couple of relevant papers recently in the last year looking at specifically at anesthesia and awareness in the obstetric subpopulation. The hypothesis is roughly as follows, that in NAP5, the incidence of awareness in obstetrics, cesarean section, was 1 in 670, and this was spontaneous reports. And this is much higher than the incidence that we'd found of 1 in 8,000 when neuromuscular blockade was used. And it matches almost the incidence after active BRICE interviewing, where you ask the patient directly about awareness after their surgery. So the question we were asking, the hypothesis was, what is the incidence of awareness if we use the BRICE interview, actively asking patients after their cesarean section? Is it going to be even higher than the 1 in 670 that we found in NAP5? So the plan was to apply this BRICE questioning to all cases of obstetric cesarean section general anesthesia over a whole year. So we conducted a study with 72 hospitals, over 3,000 cases of general anesthesia that we captured. And we found the incidence, which was 12 cases, was 1 in 212, just over 1 in 200, which indeed was very much higher than the NAP5 incidence, and is strikingly higher. The discovery that after a routine, well-managed cesarean section, 1 in 200 of your patients may well have suffered accidental awareness. And this is a hugely significant significant result. And it has a psychological insult, it has psychological impact, where 1/3 of patients we discovered had evidence of post-traumatic stress disorder, PTSD. The risk factors were interestingly similar, overlapped with what we had discovered in NAP5, notably high BMI, so the obese patient, out-of-hour surgery, and intriguingly, ketamine or thiopental for induction. Now, there's the thiopental story again, which is specific to UK practice. And we discovered that there was a subgroup of obstetric anesthesia in the UK who use ketamine routinely for their cesarean sections. And this was massively overrepresented in the awareness cases. This is the middle bar that you see here is the ketamine bar. So the first bar is the thiopental bar, and the night shift bar is this one here. The BMI one is the one at the end. So to conclude this lecture, NAP5 results have influenced clinical practice via the guidelines that I've touched upon, scientific thinking about what awareness is and what consciousness is via the research program that we made recommendations around, and also culturally via artistic dimensions. When we disseminated the project, we actually engaged an operatic company to create an operatic theme around patients' experiences of NAP5. So we hope that the NAP5 report will remain a rich source of material to fuel and inspire even more work around this important topic, as there is very much more to do. Thank you very much.